On behalf of ACCMB, I'd like to welcome you all for this weekly CME, which will be on intercostal tube drainage by Dr. Sarthak Lunawat, who is a uh, junior resident in surgical department. So, welcome, Dr. Sarthak, for your presentation.
Thank you so much, sir. Good afternoon. I'm Dr. Sarthak Ranawat, and I'll be presenting the topic intercostal tube drainage. Mic sir off karo. So, to begin with, intercostal chest drain or ICD is also known as chest tube thoracic catheter tube thoracostomy. It is a conduit inserted through the chest wall and into the pleural space to remove air or fluid from the pleural cavity. Fluid can be blood, pus, chyle, or pleural effusion. For a chest drain to be efficient, it must allow re-expansion of the underlying lung and prevent re-entry of air or drained fluid back into the chest. Now, for ICD, we must know the anatomy. So the basic anatomy today we'll learn is intercostal drain goes in intercostal space. So intercostal space is the space between the two ribs. From in this slide, I'll show you from from anterior to the posterior all the layers which we are going to pierce and what things we should be we should keep in mind while performing ICD. So the first skin, superficial fascia, followed by the subcutaneous fat, then serratus anterior muscle, followed by the three intercostal muscles: external intercostal, internal intercostal, and innermost intercostal muscle. And intercostal neurovascular bundle lies in the costal groove along the inferior margin of the superior rib and pass in the plane between the inner two layers of the muscle. So the ICD to be placed inserted along the superior surface of the inferior rib. In this slide, we can see these are the two innermost layers of the intercostal muscles and the structures passing through which are inferior to the superior uh, which are superiorly to the superior rib, which are intercostal vein, intercostal artery, and intercostal nerve. Also, we should keep in mind the diaphragm. Diaphragm is a balloon shaped, right, and the right dome of the diaphragm is much higher than the left dome because of the liver. So while inserting the ICD, we should keep in mind when we are doing it on the right side that we don't pierce the diaphragm. So ICD should be inserted always and always above the sixth rib. These are the just key points which I just told you. And now the extent of lung and pleura. While measuring from mid-clavicular line, lung extends till the sixth rib and the pleura extends till the eighth rib. While measuring from the mid-axillary line, the lung extends till the eighth rib and the 10th rib. This is the triangle of safety. This is the ideal place for the placement of intercostal drains. So anteriorly, there's a boundary by lateral edge of pectoralis major, and inferiorly there's bounded by lateral edge anterior edge of the latissimus dorsi, and superiorly it is bounded by the base of axilla, while inferiorly by the line fifth line intersecting the nipple or the fifth intercostal space, depicted by the blue color here. Now the physiology of respiration, the basics. At the time of respiration in normal lung, the pressure in the pleural space is always negative compared to the atmospheric air pressure. So while placing ICD, there's a tendency that the air can get stuck inside while breaching. There's a breach in the barrier. So we place a one-way seal, which is underwater seal bag, which acts as a, which lets the air or the fluid pass out, but prevents it going back inside. Intercostal drainage tubes. They are mainly made of PVC or soft silicon and measures from the sizes 6 French to 40 French. Conventional chest tubes feature multiple drainage fenestrations, most likely 6 holes, and they are to be placed inside the patient. As well as the distance markers are along with the length of the tube are also placed, and a radio opaque stripe outlines the first drainage hole, so we can assess it on X-ray for the correct placement of the tube. So patient preparation, we start by informed consent, preparation of the materials, positioning of the marked site, and oxygen saturation monitoring is the must while placing the ICD. Materials and methods. Materials required are sterile gloves and gowns, antiseptic solution for preparing the area, local anesthetic solution to infiltrate and prevent pain, sterile gauze, scalpel number 11 or 23, and curved and straight artery forceps. So, what's the position? Position to place ICD. Patient is made to sit, or if he's bound on bed, the bed is elevated at 30 to 60 degree, preferably at 45 degrees, and while the hand of the side where the chest is going to be placed is placed beneath his head. Now, USG guided marking of the position. After positioning the patient for the chest in, we have to identify the triangle of safety. Now, the USG probe is taken, cephalad, and scanned down from mid-axillary line from the axilla to the diaphragm. And we have to identify the lung curtain. Lung curtain is basically the extent till the diaphragm moves, and mark this level at the end expiration. This is your the lowermost extent which you can go to, and preferably you have to be above this in every case. Now we have to move to the chosen entry point and confirm the absence of lung sliding and mark this point. Lung sliding is the two bright lines on the USG, which is basically the visceral parietal pleura and the visceral pleura. Now I'll show you the curtain sign.
Thorax and the abdomen, we see the lung curtain. So the patient breathes in, it comes down, obscuring the abdominal organs, and they breathe out, and it goes back up, revealing them again like a curtain. And it's at the point of end expiration that we would mark the level of the diaphragm, because we want to make sure we're above or cephalad of that point.
So here you can see, I'll just a second, I'll play the video.
Thorax and the abdomen, we see the lung curtain. So the patient breathes in, it comes down, obscuring the abdominal organs, and they breathe out.
Here this moves, this is the lung curtain. It moves
at the
when breathing in, and it goes up when breathing out.
So we want to make sure we're above or cephalad of that point.
This marks the, and we should always mark the location while in end expiration. One second. Okay. So this is a study in which finding the fifth intercostal space for chest drain insertion and manually and as compared to the ultrasound. So first of all, we should use USG if available to mark the correct position and prevent injury. This study indicated that in women's, marking the location by the nipple of fifth intercostal space usually can lead to damage to the diaphragm. So use of USG is a must, and in centers which do not have USG, new guidelines should be in place because the ones which are working can cause trauma. So, yeah. Now preparing the skin and local analgesia infiltration. First, we clean the skin with povidone iodine and chlorhexidine solution to and allow it to dry for asepsis. Then the site is draped with the fenestrated sheet, and using the 10 ml syringe and 25 gauge needle, we raise a skin wheel at the incision site and give 1% location solution of lidocaine. Here we can see, as I have earlier talked about the anatomy. Here we can see the structures, vein, artery, and the intercostal nerve. So the nerve lies just beneath the groove, intercostal groove of the rib. So it is very easy to provide analgesia. So we liberally infiltrate the subcutaneous tissue and intercostal muscles of the intercostal space where the pleura entry will occur, and down to the right down till the parietal pleura. Next step is the incision. We make a incision 2 to 3 centimeters transverse through the skin and the subcutaneous tissue overlying the interspace, which we have already marked. Now we extend the incision by blunt dissection through the fascia towards the superior aspect of the rib above. After the superior border of the rib is reached, we close and turn the artery of forceps and push it through the parietal pleura with steady fingers and even pressure. Then the artery forceps, which are widened, are closed and then withdrawn. We have to be very careful to prevent the tip of the clamp from penetrating the lung. Now we insert an index finger to verify that the pleural space, not the potential space between the pleura and the chest wall, has been entered. We have to check for any unanticipated findings such as pleural adhesions, masses, or diaphragm in cases of diaphragm herniation. Now ICD insertion. The ICD tube is grasped by the tip of the forceps and advanced through the hole which we just made into the pleural space using our fingers as a guide. The tip of the tube is posterior for the fluid. This is the actually the placement, which is ideal, but it doesn't make much difference. The tip of the tube posteriorly for the fluid drainage or anteriorly and superiorly for the pneumothorax evacuation. We have to keep in mind that we have to advance the tube until the last hole is 2.5 to 5 centimeters inside the chest wall. Now, how to confirm the position of how we have placed the ICD. To confirm the correct location of the chest tube by visualization of column movement within the tube with respiration or by drained pleural fluid seen within the tube, we ask the patient to cough and observe whether bubbles from the water at sea level are, if there are any bubbles. If the tube has not been properly inserted in the pleural space, no fluid will drain and the level in the water column will not vary with respiration. Here we can see the placement of tube. So then the tube is fixed with silk and proper dressing is done, and we have to take necessarily the X-ray post procedure for the correct positioning of to check the correct positionings of the tube. Now do's and don'ts. We have to keep the chest tube below the chest level, so there's no backflow. Tube has to be secured to the chest wall, and bag must be filled with sterile water up to the mark line, which is ideally at 100 ml. We have to also check for if there are continuous bubbling and continuous blood in the tube. We also encourage patients to cough. Physiotherapy helps in better prognosis. Pain management and respiratory exercises are motivated in a patient. Daily auscultation SpO2 monitoring should be done. We also need to check for the local site for subcutaneous emphysema, and we should never clamp ICD drain. Okay. So we have talked about the insertion of ICD, but now when to remove? Removal of ICD must be done when the condition why it was placed resolves. In case of pneumothorax suction is stopped and the tube is placed on the just water level seal for several hours to ensure that air leak has been stopped and the lung remains expanded. Chest X-ray is often repeated 12 hours to 24 hours. The last evidence of air leak was there. For pleural effusions or hemothorax, the tube is typically removed when the drainage is less than 100 ml per day or 24 hours. Now complications while inserting ICD. It could be misplacement, tube could get displaced, tube inserted too far, tube placed subcutaneously. Subcutaneous surgical emphysema could also be there due to the air leaking just beneath the sutures, just beneath the incision site, injury to the organ and other structures. And there could be injury to diaphragm, to parenchymal of hilar injuries, lung lacerations, injury to heart, phrenic nerve just goes right there. Phrenic nerve injury could also be there. Neurovascular bundle injury, esophageal perforations, which can lead to hemorrhage, bowel injuries in the presence of unrecognized diaphragmatic hernia. There could be contralateral pneumothorax and hemorrhage and hemothorax. These were the early complications. Now we talk about the intermediate complications: surgical emphysema, re-expansion, pulmonary edema. If the lung is allowed to, if it's drained very early, so it could lead to re-expansion pulmonary edema. There could be tube blockage and infection along the chest tube if proper care has not been taken place. Now, late complications. Late complications could be retained hemothorax due to the incomplete drainage, pneumothorax after the removal. While removing, air could leak inside, which can lead to further pneumothorax, empyema, pus formation, abscess, and fistula formation along the tract of the ICD. This is an article which shows that if ICD is placed safely and aseptically, it it improves the pleural conditions and pleural diseases. This article compares ICD versus aspiration, needle aspiration. So the immediate success rates of ICD are much better than needle aspiration, but ICD has usually led to longer hospital stays, and particularly you have to take good care while the ICD is placed. And also it has been noted that the fewer adverse events were in the case of aspiration as compared to ICD. Thank you so much. This has been my presentation. Thank you, sir.